Hi, this is Professor Tagwire here. Um, Unit 6, as we go on with our course. It's first aid exposure, first aid after exposure to snake venom. And I chose that term exposure. I don't want to say after being bitten by a snake or after snake bite, because the person can be exposed to snake venom via the eyes with the snake not necessarily biting them. So, what we want to achieve? So, by the end of this unit, the participant will be able to describe what first aid measures are to be taken when a snake spits into the eyes of a patient. Two, must be able to briefly discuss the do's and don'ts when it comes to first aid management of a snake bitten patient. And three, to be able to briefly describe how to apply a pressure bandage in cases of snake bite, as well as maybe say one or two things about the theory behind the procedure. And from the outset, I just want to make this clear that this unit 6 is actually best taught in a practical setting, and in this particular case, we're just doing it as exposure, so that the healthcare professional knows what they should do. But in terms of the actual psychomotor skills that would be required to do the first aid, our team will be working on coming up with an actual hands-on, face-to-face instruction on first aid after someone has been bitten by a snake or after somebody has been exposed to snake venom. Basically. So just an overview of the management of snake bite. So in this session, we shall look at three. In fact, in this particular section, we're going to look at two aspects of first aid management of snake venom. So this is first aid after eye exposure to venom and first aid after a snake bite. So moving right on to the first one. So we do have some snakes which are in the habit of squirting or spitting or spraying venom into the victim's unsuspecting eyes. And we saw this earlier. And now if we were in a face-to-face classroom type of situation, I would be picking on participants and saying, okay, give me the name of a snake which spits. Well done, the Mozambique spitting cobra. And is there any other snake that we know of in Zimbabwe that spits? Yes, you with the red t-shirt. Okay, that's what I would be doing. But another example would be the wrinkles, isn't it? So here we have somebody who's been spat in the eye and conjunctivitis, quite red. The eye is pretty red, isn't it? So when someone has been spat in the eye, most of the times it is quite normal that the venom gets into one eye as opposed to both eyes, although you do get situations where it does get to both eyes. But what you really want to do is to flush the affected eye or the affected eyes with copious amounts of water. So you want to keep on pouring the water, you see here, and pouring it and pouring it and pouring it for at least 20 minutes if we're going to avoid any serious damage occurring in the eye. And after that patient, even during as you're going to the hospital, you can continue to pour and pour and pour and pour, but then that person should be taken to a medical center. If you've done your 20 minutes, you can cover the eye if the hospital is far, and then rush them to the nearest medical center. And as you're pouring the water, you want the patient to be blinking repeatedly, as the eye is being flushed to try and get rid of all the venom in the different corners of the eye. And just a reminder that assuming, like in this picture at the bottom, that this is the eye that has been affected by the venom, you want to pour the water from the unaffected eye. Oops, let me rephrase that. Yes, from the unaffected eye into the affected eye. So this is the direction that you pour the water from the unaffected eye to the affected eye. You do not want to do it the other way around, because what you might just do is to move or to flush some of the venom out of this eye, and it then affects the unaffected eye. And instead of having one eye affected, now you've got two eyes which are affected. And like I said earlier, when you're talking of potency, some of the venoms are pretty potent, meaning that even a small amount, micromilliliters, can actually cause significant damage to the eye. And in the cases where there is no water, try to find some other, in quotes, soft fluid or non-corrosive fluid you can use. Milk. And others have argued that if you're out in the bundu and you're by yourselves, perhaps even using urine might be a good idea. But well, your guess is as good as mine on this one. I suppose if you have to save the patient from blindness, then whatever fluid that you can use, as long as it is not a corrosive one or an irritating one, please go ahead and just use it. You might just save somebody's eyes. And then I took this off the WHO publication, and it's just a quick overview of what's recommended for venom ophthalmia. So from a first aid perspective, you want to immediately irrigate with water or other blend solution. So you want to be opening and closing the eyes under the water, and we've already seen that. And then because we're not going to talk about exposure to or the management of people who've been spat in the eyes at a hospital setting, when a person gets to the hospital, there must be a single application of a local anesthetic, eye drops. And this will help because most of the times, when your eye is irritated, there's a tendency to want to keep the eyelids shut pretty tightly. So when you give a local anesthetic, it might overcome, the tightly closed eye, that particular reflex that comes to people, and it actually facilitates irrigation. And then you want to check for the amount of the damage through fluorescein staining. You do a slit lamp, check for corneal erosions. If there are no corneal erosions, then you can just give an antibiotic ointment, give an iPad, and normally after 2 days the patient should be just fine. But if there is a corrosion which can be seen, you want to give an antibiotic. If there's a mydriatic, you give that as well, and then you want to give them an iPad as well, and you want the patient to come back every day for daily slit lamp examination until they've been cured. So I hope that does make a bit of sense. So some things which have been done by people in the past which you might not want to do. For example, others have decided to use antivenin, dilute antivenin topically or even systematically, and this is basically not indicated. Because generally, as you shall see with antivenin, it's an exogenous substance. So what the body might do is to then mount an anaphylactic reaction, and you don't really want something like that occurring over something which can be treated topically. And others have talked about giving steroids either topical or systemic, and that's not a good idea because steroids in themselves, they cause thinning of or mucous membranes, like even on the skin, and they actually increase the likelihood of a person actually acquiring infections, and you don't really want to expose them to steroids. You want to encourage the patient also not to rub any herbal or home or traditional remedies in their eyes. Chatting to one of my colleagues who's an ophthalmologist, they've seen lots of cases of blindness that has occurred after people have put in some home remedies and traditional remedies in their eyes to manage eye ailments. And then whilst we're here, in case the venom doesn't get into the eye but goes somewhere else, like in the mouth, you want to wash with water or some other blend solution. If it is on the skin, you just want to wipe it off or wash it off because the likelihood of anything serious occurring here is not as high. Although there are some cases of people who are hypersensitive to snake venom and have had serious reactions even after the venom has gone on their skin. But that's not our subject for here today. And then now with regards to a snake bite, there are some things that you must think about, some things that you do not wish to do. Number one, do not cut and suck the bite site. We used to see this in the old Western movies where someone is bitten by a rattlesnake, and then some rugged cowboy comes with a huge knife, slits, puts two incisions, or one incision by the bite site, and then he sucks it up, spits the venom, spits the venom, and then suddenly the other guy he's up and he's strong and he's like, "Oh, I owe you, cowboy. You saved my life." But you don't really want to do that because these days there's HIV/AIDS. Secondly, that procedure has not really been demonstrated to reduce the envenomation. Um, and thirdly, if you're dealing with cytotoxic envenomations and you're cutting a place where cytotoxicity is going to occur, that might not work out too well. In the past, they also used to advocate the application of ice packs, and the theory behind that was that if you put an ice pack, then you cause vasoconstriction, and then that would stop the venom from spreading very fast. And again, there's no science to support it, clinical evidence to support that. And if you're dealing again with cytotoxic envenomation, it might just make things worse. With regards to a tourniquet or a tourniquet, I've put a question mark there because there's lots of argument within the toxinological fraternity as well as in the medical fraternity with regards to their use. It is agreed generally that you do not wish to use a tourniquet in cases of cytotoxic envenomation. There is no question about that in general. But then there are arguments that if someone is bitten by a really large black mamba or a very large, snouted cobra, perhaps applying a tourniquet might save the patient. But the whole idea is if you're going to apply a tourniquet, you do not want to apply something which has got a small diameter or a small width, not diameter, but width. But you might want to use something a bit thicker. And the moment you apply a tourniquet, you must be aware that when a patient comes, especially after a neurotoxic snake bite, to the hospital or medical facility with a tourniquet tied, they must be in an emergency room. And it is generally suggested that you want to give them some adrenaline, perhaps, and give the anti-venom before releasing the tourniquet. Because if you don't, there is a venom storm that occurs. And some people have actually died at the hospital because the venom is released so quickly and affects so many body parts very quickly. And then a person fails to make it. Then you do not want to make any incisions at the bite site. And definitely you do not want to chop off the limb because you might chop off the limb when someone has been bitten by a snake, which is actually non-venomous, or chop off a limb when actually it was a dry bite. So you don't really want to do that. But what do you want to do? Well, you want to try and keep the patient as calm as possible, and that's easier said than done. I've had students ask me in class when I say this, when I suggest keeping a patient calm, and they say, "Sir, can we lie to the patient and say the snake that bit you is a non-venomous one?" And I'm like, well, if he's going to save them, perhaps, but well, ultimately moral issues are between yourself and your God. But really, if it's going to keep the patient calm, you want the patient to be as calm as possible. If you can, calm them by telling them that dry bites do occur or whatever else, look for strategies to keep the patient calm. You want to wash the bite site with soap and water. And the reason why you want to wash the bite site is, like we said earlier, some snakes have got very potent venoms, meaning that even if a small teensy weeny bit of a drop gets into the circulation, the effects that you might find coming up may be pretty significant ones. So you want to eliminate whatsoever venom might still be on the skin, and that's why we wash it. And then there's what is called a pressure bandaging with immobilization. And we'll talk a little bit about it in the next slide. But like I say, these are things which are best left for more practical sessions. And the interesting thing about this pressure bandaging, it was started off by some Australian researchers, must be Sutherland and colleagues in the mid 1980s. And what they did is they discovered that through some experiments with monkeys, that the venom of most Australian snakes seemed to move through the lymphatic system as opposed to the veno-arterial system. So their theory was If the venom goes through the lymphatic system, if you can apply a pressure bandage along the limb and put sufficient pressure to occlude lymphatic circulation, but not veno-arterial circulation, then you can actually slow down the movement of the venom. And it does make a bit of sense. What I'm not sure of is whether this has been done for our African snakes like your black mamba or your Cape cobra in South Africa or the snouted cobra here again in Zimbabwe. But yeah, that is the theory behind it. And it's generally not recommended when you're dealing with cytotoxic snakes to do pressure bandaging. In fact, when somebody is bitten by a cytotoxic snake, you want to actually encourage the victim to move the bitten limb. So if it's the hand, you want the victim to be moving the hand, even elevating the hand to try and reduce the swelling. Because like we saw earlier, if the swelling becomes too much, it might be necessary, for fasciotomy to be done to be able to release pressure so that the limb can be saved. And then ultimately you want to rush the patient to the hospital. So this is what pressure bandaging looks like, or pressure immobilization. So basically you've got a broad pressure bandage that you use. You can try to use a crepe bandage, but it's really hard to get the necessary pressures, which I think they've been said to be approximately 70 millimeters of mercury. So that's the bite side. So you'd bandage all the way up, like they're doing there, and you come down, apply the pressure, and then you'd have a splint so that the patient does not move their limb. And you do not want them to move their limb. Why? Because when you move your limb, then you can also facilitate the movement of the venom. So that's what pressure bandaging looks like. And like I said, it's something that we'll talk about a bit later when we have face-to-face instructions. But that's basically what it would look like. So because it's high pressures, there are some commercially available pressure bandages. Here is one from the African Snakebite Institute. And the way that it works is before you pull it, these will be rectangular. And the theory is when you pull it taut enough, the rectangles must become squares. So when the rectangles are squares, then you know that the pressure that you are actually applying on the bitten limb is within the pressures that are necessary to occlude lymphatic circulation. And here's another snakebite bandage. So there are now several commercial ones, most of which have got patents to them. Although others have argued that even if you do not have this, just try to use a crepe bandage. Make it as tight as someone like you'd make it on someone who's had a sprain. But again, a very interesting area for research, still debatable. That is my final slide. It's actually available on the African Snakebite Institute website. So it basically talks about first aid for snake bite. And I'll go through it quickly. So if somebody's been bitten by a snake and the snake responsible has been identified, you want to immobilize the patient and promptly transport to the hospital. So that's where you do the pressure immobilization. So if the snake responsible has not been identified, you also want to do the same thing. So if the snake is a boomslang or with twig snake, you also want to do the same thing. So this might actually help. Yeah. So if it's identified and it's not a cytotoxic one, then we're moving on to the cytotoxic one. So here the cytotoxic ones, you see the adders, stiletto, and spitting cobra bites. So if somebody has been bitten by any of these, the ones that we have in Zimbabwe is that one, we have that one, we have that one. The berg adder, remember the berg adder, the way it's got cytotoxic and venomation, it's also neurotoxic. The stiletto snake, the wrinkles, and the Mozambique spitting cobras are the ones that we have in Zimbabwe. So you want to elevate the affected limb slightly above the heart and immobilize the limb, so you don't want the person to be moving. Then, you'd actually want to facilitate the person to be moving. So I beg to differ slightly here. And if there's pain and swelling, same thing. Slightly elevated, encourage the patient to move. So if it's a neurotoxic snake, the ones that we have in Zimbabwe, the black mamba, green mamba in the eastern highlands, snouted cobra, Anchiates cobra, you want to wrap the affected limb in pressure bandages and apply a splint. So here, immobilization, pressure bandaging, no pressure bandages. And if the patient is experiencing difficulty in breathing, you might want to do mouth-to-mouth resuscitation. And if you've got a bag valve mask, well, that'll be a time to use it. So if the patient experiences difficulty in breathing, you want to assist them with their breathing. Okay, I thought this was going to be short, but apparently not as short as I thought it was going to be. It's just gone past 20 minutes, but I trust that. So today we were just looking at snake bite first aid, and I trust that you learned something. And until we meet again, this is Professor Tagre. I say I'll see you in Unit 7. Otherwise, for now, au revoir, goodbye, have a good day, enjoy your quiz, and pass, please, pass.